Good morning. I'm Samantha Richardson, the Director of the Governance and Impact Analysis Group in the Office of Burden Reduction and Health Informatics at CMS. It is a pleasure to be here with you today and to welcome our panel, Reducing Burden and Optimizing Patient Care Delivery across CMS programs. We have a fantastic discussion planned for you focused on how CMS is taking action to improve patient care delivery, engage stakeholders, and address administrative burden in our programs. I am pleased to introduce our panelists. Jean Moody Williams, who serves as the Deputy Center Director for CMS's Center for Clinical Standards and Quality, or CCSQ. She leads the team that focuses on policy activities for quality improvement programs, end-stage renal disease networks, survey and certification, quality measurement and health assessment, clinical standards, coverage and analysis, quality innovations models, and many of the agency's value-based purchasing and public reporting programs for hospitals, physicians, and ambulatory settings. Dr. Doug Jacobs, he is the Chief Transformation Officer at CMS. He helps lead Medicare's efforts to promote value-based care, advance health equity, and encourage delivery system transformation. Dr. Jacobs is a practicing board-certified internal medicine physician and is an assistant professor of clinical medicine at Penn State Hershey Medical Center. Dr. Aditi Malik. She's the acting director of the Office of Minority Health at CMS. She leads advancement and integration of health equity in the development, evaluation, and implementation of CMS's policies, programs, and partnerships. Prior to joining OMH, Dr. Malik, served as Chief Medical Officer for the CMS Center for Medicaid and CHIP Services, where she led the center's clinical strategy and cross-center work on health equity, social determinants of health, and innovation in whole person care, among many other areas. And Dr. Sean Michael. He is one of our agency's regional chief medical officers. He's located in our Denver office and provides clinical expertise around payment, policy, quality improvement, survey and enforcement operations, contracted health plans, and data analytics. And he serves as the principal liaison with the clinical community. Dr. Michael was previously the emergency department clinical and medical director at the University of Colorado Hospital, the highest volume ED in the region. And he practices clinically and serves on faculty as an associate professor of the University of Colorado School of Medicine. I'd like to welcome all of our panelists. So what we're going to do is jump right into some questions. And as you're hearing the questions, please feel free to enter your questions into the Q&A. So we're going to begin with Jean. One of the successes of our agency's response to the COVID public health emergency, or PHE, was the way requirements were eased so care could continue to be delivered safely, but in a very changed environment. Can you share with us how the agency approached the easing of administrative requirements during that time?
Sure, thank you, and thanks so much for inviting me. I'm really excited about being on this panel with my esteemed colleagues. And, I would say by its very nature, 1135 waivers, the flexibilities, and emergency regulations, it is primarily about temporarily easing administrative requirements. In fact, 1135 waivers were enacted to allow CMS to waive various administrative requirements to increase access to medical services during a time of a national emergency. The waivers are intended to ensure that sufficient healthcare items and services are available to meet the needs of the Medicare, Medicaid, and CHIP beneficiaries, and also so that healthcare providers that provide the services, they're doing it in good faith, And we're easing the regulations, and we want to make sure that they can be reimbursed for them and not be subject to sanctions for noncompliance. Now, the caveat, of course, for my CPI colleagues is that's absent any fraud or abuse. But we want to make it easy for clinicians to be able to do the work and beneficiaries to access care. It's important to note, though, I want to point out that there are two requirements that must be met for 1135 waivers to be issued. The first must be a presidential declaration of a disaster or emergency under the Stafford Act or National Emergencies Act, and the HHS secretary must declare a public health emergency under the Public Health Services Act. And I mention this as we frequently get requests for us to continue a waiver or ease an administrative requirement or expand the waiver period. And we don't have the ability to just automatically expand a waiver in the absence of an emergency. On occasion, we can temporarily use enforcement discretion, but you can tell by the term that that's not a permanent solution. I also mention this because it's important that when a governor or an official request an emergency declaration, that they really think through the impacted areas that will need the administrative relief. Because only the impacted counties, if you only include those counties in the request and don't consider the surrounding counties, those surrounding counties may be needed for some of the surge capacity in order to care for those that need care. Now, during the PHE, we implemented waivers that were specifically designed to remove administrative burden. For example, medical records requirements. So we know that they have to be completed within 30 days following discharge. Well, we eased that requirement during the PHE. For quality assurance and performance improvement activities, we limited it to you're required to focus on adverse events and infection control for obvious reasons, other than the full-blown data-driven QAPI. We waived many of the requirements as it related to life safety codes, documentations, policies and procedures related to temporary expansion sites. And so those waivers enabled hospitals to meet the needs of Medicare beneficiaries in what we might consider non-traditional locations. I will say that there were certain flexibilities that we granted that we ended prior to the PHE because although they may have alleviated some burden, they didn't contribute to the well-being of the people we serve. One example is we waived the requirement for submission of nursing home staffing data. Well, we quickly found out that without this data, we really didn't have a lot of transparency as to where there were staffing shortages, where we needed to send strike teams, maybe where National Guard needed to go. We were being asked for this information and we didn't have it. And so that was one of the first ones we ended. I will note that we had a team of policy experts, practicing clinicians that work at CMS. We do have practicing clinicians at CMS, senior leaders, and others that reviewed every single waiver on a continuous basis to determine if they should end with the PHE and sooner or be made permanent through regulations if we had the ability to do so. The other alternative, if we didn't, was maybe consideration in the president's budget.
I'm asking if any of the other panelists wanted to add to the response of that question. Thank you. Okay, great. So, Jean, while it was great to have the flexibilities and many ended with the PHE, what's happened during the unwinding? And do you have additional plans for the future?
So I think there are two questions in that. The first was about unwinding the PHE. Right. So it was a top priority to ensure that when the PHE ended, that the transition followed an orderly process that minimized beneficiary and provider burden. And CMS, with input from HHS, we completed, and OMB, we completed the unwinding of flexibilities in over 160 blanket waivers. There were 6 emergency rules. There were 75 quality safety oversight memorandum, which is kind of subreg guidance. And we received over 267,000 individual waivers. So we had to unwind all of that on the Medicare side, and then the Medicaid side had to look at all of its state waivers and that it had granted, as well as enrollment considerations. So on the Medicare side, we began to think of our work really in three phases. So how do we end the current emergency waivers and flexibilities? How do we prepare for the next event? Because we know there'll be a next event. And then the overall system resiliency was kind of the third part. And I would say that the pandemic really revealed opportunities. It was a tragic situation, of course, but it did reveal and sped up some innovations, I'll say, in areas such as technology, connectivity, operations, emergency preparedness, and really, excuse me, the need to address underlying disparities in health and healthcare outcomes. The Consolidated Appropriation Act really extended many of the flexibilities, such as telehealth, through December of 2024, so next year. And then we finalized a number of those provisions in the physician fee schedule that was just published earlier this month. The Act also extended the Acute Care Hospital at Home initiative, which was extended also until next year. And I note that hospitals can and are continuing to apply for those for the hospital at home waivers. As a matter of fact, we just approved an application this week. We did publish a few weeks ago in JAMA that there were more than 11,000 patients admitted under this waiver, and from November of 2021 until March of this year. So also in phase 2 of the unwinding, we use lessons learned and assessment of flexibilities to inform what next steps would be. And we kind of formed a playbook of flexibilities that CMS could consider to turn to quickly if needed in response to emergency. And we have had plenty of practice, I should say, since that time, with the typhoon in Guam, the flooding, the water issues in Germantown and Tennessee. Of course, we've had hurricanes and wildfires in Hawaii. So there's always constantly work being done. Now, the second part of the question talked about plans for the future. And many of CMS's recent strategies, but specifically the CMS National Quality Strategy, the Framework for Health Equity, the Behavioral Health Strategies, and several others, they build on learnings prior to the pandemic, but really strengthen those learnings that we learned during the pandemic. And so we're following those frameworks. We continue to get requests for consideration for administrative relief related to things such as scope of practice. So for advanced practice clinicians and other physicians. And in most instances, in that case, we defer to state regarding licensing and scope. But some of the flexibilities were extended and others will end this year. But I do want to say, because we get these requests, that even though the emergency is over, if it's in a regulation, we can always and are continuing to assess those. We are in the midst of developing a formal report to Congress using a mixed method evaluation approach of the effectiveness of CMS flexibilities to respond to the PHE. We're looking, we're using emerging literature, information from various sources. We're doing some quantitative analysis and interviews. So I want to just take this time to invite anyone listening to share information that you would like us to consider. And we have many incoming correspondence. We've cataloged those. We're outlining the challenges. And we really, we witnessed remarkable resilience within the healthcare system. And I believe that as a country, we can obviously do better, but we are resilient and we're going to work together to strengthen what we see in the future. Thanks.
Thank you, Jean. Thank you. Anyone on the panel want to add to this?
I have to just highlight what Jean said at the end with sort of the work that's happened, sometimes with sort of small natural experiments, right? A terrible circumstance resulted in individual healthcare organizations, individual clinicians, entities, practices being able to figure out a new way of trying something. And it changed the activation energy a little bit, right? It allowed people to try to innovate in a way that they might not otherwise have thought of or been able to do before. And many of those discoveries are burden reduction discoveries that we can benefit from and that we can help scale nationally when we can incorporate those lessons. And so I really think that, Jean gave so many good examples of things that have happened at the national level and the sophisticated thought process that's got into this. And there are so many organizations and so many audience members today and so many other healthcare delivery leaders out there who have put in that same level of sophisticated thought process. And we really want to hear those ideas. And we really want to be able to incorporate that into the broader good.
Definitely.
Maybe I'll also add one of the other, I think, silver linings of the pandemic was the expansion of telehealth in particular. We have seen after the expansion of telehealth just how much easier it is for folks to get access to, for example, behavioral health care. And we know that behavioral health related morbidity has really become such an acute problem across the country. And so in response to some congressional action, we actually permanently extended access to telehealth for behavioral health services and extended the telehealth waivers more broadly until the end of 2024 in Medicare. So anyways, just wanted to add that this expansion of access to care and also not only audiovisual technology, but audio only, speaking to the importance of that, particularly in rural and underserved areas where broadband access is hard.
Yes. Thank you. All right. Thank you all. The next question is for Doug. So you helped to lead the agency's work to move from a fee-for-service system of reimbursement to one that pays for more quality care and outcomes. Can you speak about how the agency thinks about administrative burden and how it relates to quality improvement from that perspective?
Yeah, absolutely. Thanks for the question, and thanks for having me here today. I think over time, what we've seen is a quality measure proliferation, which is in many ways a good thing. We can measure aspects of our healthcare system that we could never measure before. And we can get an accurate representation of quality in ways that we never have been before. And CMS operates more than 20 quality and value programs, sometimes quality reporting programs, sometimes that's tied to payment in more of a value-based care arrangement. The challenge comes when a lot of the measures don't align and might conflict for the same practitioners. So practitioners see patients across Medicare, Medicaid, commercial insurance carriers, and a lot of clinicians don't really necessarily look at what payer is paying for the care that each individual patient is coming in to see the physician for, which I've seen firsthand as I see patients as well. And so when there's different quality measures in these different value-based care arrangements or quality reporting programs, and there's a lack of alignment, it can be really challenging and add to administrative burden from a clinician standpoint. And so something that the agency has done really across our centers is come together and create what we've called the universal foundation of quality measures. And what this is it's a building block approach. So it's a baseline foundation of quality measures across as many quality reporting and value-based care programs as possible. And then with the recognition that there is also going to be differences in different care settings and by payers. And so there would be aligned add-ons for those different care settings or payers. And so having that universal foundation of quality measures across programs really can allow clinicians to focus their energy when they're going through their panel, trying to make sure that they're adhering to quality measures. It can also make it so that as we're moving towards digital reporting of quality measures, these measures can be prioritized for digital reporting. It can also make it so that we have a set amount of measures to stratify, to identify some the disparities that we know exist across our healthcare system. And so as we are, we're continuing to roll out the Universal Foundation now. Just recently, when in the finalized physician fee schedule, we incorporated the Universal Foundation measures into the primary care MIPS value pathway, or MVP. And it's also been, certain measures have been started to be incorporated in Medicare Advantage and Medicaid. So we're taking one turn of the crank with each rulemaking cycle here to start incorporating these measures. So The Universal Foundation is part of the National Quality Strategy also that Jean Moody Williams mentioned, and it includes several other different components. I won't get into those today, but we're really working in aligned fashion across CMS to make sure that we are improving quality in any way we can. Additionally, I wanted to highlight one other area, and this is an area that we've heard from clinicians over time about about the burden that it creates, and that's specifically with regards to prior authorization. And in Medicare Advantage, we have now finalized important rules relating to the use of prior authorization procedures that go into effect January 1st, 2024. And so that overall includes things like ensuring that the prior authorization that occurs in Medicare Advantage is no more restrictive than what exists in traditional Medicare, and that the prior authorization procedures have to be transparent and made public. And then there's also specific requirements for the processes that happen at the Medicare Advantage organization level, having a committee that reviews the evidence behind these prior authorization requirements. And we also recently proposed an additional rule for Medicare Advantage that says, and the proposal would require Medicare Advantage organizations to conduct a health equity analysis for individuals with social risk factors to make sure that the prior authorization criteria aren't having a disproportionate impact for them. So we're excited about a lot of these finalized changes and proposed changes, and looking forward to participating in the rest of the conversation. Thank you.
Thank you. Thank you. Does that touch on rewarding excellence for underserved populations?
So yeah, I can talk a little bit more about that too. So as part of the national quality strategy, and I think Dr. Malik will get into some of the equity related work as well. But as part of the national quality strategy, equity is a big piece of that. And equity is an important pillar across a lot of what CMS does. And so as we're thinking about how quality and value and payment interact, we've come up with this aligned strategy for rewarding excellence for underserved populations. And what that means is across different value-based care arrangements, we are identifying providers that treat a disproportionate amount of the underserved population, giving them an upside-only reward if they provide excellent care to those underserved populations. And the reason that we've adopted this approach is that it avoids some of the other pitfalls that could be like pay for equity type approaches. It doesn't risk adjust away disparities, thereby masking them. It doesn't set lower standards for underserved populations, such that they're not receiving excellent high quality care. By having an upside only reward for plans and providers that are treating a disproportionate amount of underserved folks, it really also allows them to, with this reward, to reinvest in the care that is delivered to those underserved populations as well. So we've implemented this now across the hospital value-based purchasing program, this skilled nursing facility value-based purchasing program, both run by the Center for Clinical Standards and Quality, and also we've finalized changes in Medicare Advantage with the Health Equity Index, and also in traditional Medicare, the Medicare Shared Savings Program through a health equity adjustment. So lots of exciting work there as well as we think about how to combine quality and payment and equity.
Very exciting. Thank you. Would anyone else like to comment on that topic? Or prior?
I'll just note that on back to the universal measures, that really is really important in that it gets us all moving in the same direction for improvement purposes. You know, we don't just measure to measure, we measure for improvement. And even within our quality improvement organization, we are incorporating those universal measure sets so that we can focus our work. Now, that doesn't preclude innovation and new measures, because I know people often worry about that. And we're moving in CCSQ to digital measures to reduce burden and capturing quality. So that still exists, but we do have this focus now, and you can feel it across the agency of us all kind of working together.
That's great.
I would just add too, I think there's the importance of the Universal Foundation too, is the ability to look at the same measures across different programs, right? So both within traditional Medicare, Medicare fee-for-service, but also in Medicaid fee-for-service and Medicaid managed care to the extent applicable. So the goal is, as Jean said, in the spirit of quality improvement, to be able to trend over time, but to also be able to make programmatic comparisons in the spirit of equity and identification of disparities, right? We want everyone impacted and serviced by CMS programs to experience high quality care. And the Universal Foundation is one way for us to level the playing field, so to speak, or at least identify what a level playing field could look like.
Great. Thank you. Thank you very much. So we're going to ask a question of you right now, DT. So you've recently been named our Acting Director of Minority Health. Before that, you worked in our Center for Medicaid and CHIP Services. Burden can disproportionately impact people based on their specific background, lived experience, and circumstances. I'm wondering if you can speak about some of the data points and trends you're most focused on in your position. And also, what should people be most mindful about related to the work that comes from your office?
Yeah, thanks for the question. I think maybe I'll start by saying there's burden to the individual, right? Burden to the enrollee by virtue of many times by virtue of their lived experience or their background. And I would say, and Dr. Jacobs alluded to this, there can be disproportionate burden or challenge associated with taking care of, on the clinician side, associated with caring for an individual who might have unmet health-related social needs or who has been negatively impacted by discriminatory systems throughout the course of their life, right? And so I think the burden cuts both ways is my point. With respect to data points and trends, I'll highlight a few things. One is sociodemographic data collection. Our office, and really with many of the colleagues on the phone and folks not pictured here, is really thinking about thoughtful data collection to identify disparities. So this isn't data collection for data collection's sake. It's in the spirit of quality improvement, truly as a means to assess and track disparities. So things like self-reported race and ethnicity, or imputed for those that are familiar with that term, utilizing an individual's name and their location to understand what their likely race and ethnicity is. Geography for individuals that live in urban versus rural areas. Primary language, right? Many people served in our programs are not native English speakers or primary English speakers. 1 in 5 Americans in the United States lives with a disability, and we need a better way to identify who those individuals are and understand the barriers to their care, because again, many of them are served by our programs. And increasingly a look at sexual orientation and gender identity, where applicable, and again, with appropriate data privacy and security, to ensure that individuals that do identify as LGBTQ plus have access to the care that they need and deserve. And alongside those data collection efforts, our team runs and releases a variety of stratified reports to highlight where there are disparities, for example, in hospital admissions, or where there are disparities in a variety of health plan level measures, or between urban and rural communities. So taking what we've discussed earlier in this conversation around a foundation of quality measurement and saying, how can we use those to identify and track disparities and ultimately eliminate them? A couple other areas that I would highlight, the one that we've talked about already, the idea of addressing social drivers of health. We know that social drivers of health account for a disproportionate impact on downstream outcomes, in fact, more so than direct clinical care does. So across a number of our programs, including Medicare, Medicaid, and in the marketplaces, a look at things like thoughtful screening for health-related social needs, incentives, including on the payment side, to care for individuals that might have unmet health-related social needs, for example, people with housing instability, people with nutrition insecurity, And in Medicaid in particular, I'll highlight specifically federal funding to go towards addressing those unmet health-related social needs for individuals that have an identified or an assessed clinical and social need. So, for example, home-delivered meals or housing navigation services, because really we've, and there is ample evidence to support this, intervening in those upstream issues can have not only remarkable positive impact on an individual's health, but it also can have cost savings programmatically, right? So can potential to be a win-win. And, I'll just reflect on my own experience as a clinician. There's a certain amount of moral injury that takes place when you are taking care of someone when the clinical care is really the Band-Aid for a broader social issue. And so I think the ability for us, and every single one of us on the phone is a clinician, has been a clinician. Many of us are still actively practicing clinicians. And the idea that we can, in our current roles through policy, impact those upstream drivers of health is really exciting. And feels to me like yet another way to reduce burden, in particular, the burden associated with moral injury. Mindful of time, I'll just highlight one other thing, which is our work specifically focused on rural, tribal, and geographically isolated communities. I would be remiss if I didn't mention that tomorrow is National Rural Health Awareness Day. So happy day to all of you that honor that remembrance. But we collectively are keenly aware of the unique challenges that providers in rural and frontier areas face, right? Issues of access, issues of workforce that really impact, again, burden on clinicians, providers, as well as on enrollees and beneficiaries in our programs. So we pride ourselves really on bidirectional input, right? We engage in outreach and education so people understand some of the flexibilities that Jean mentioned, or they understand some of the payment incentives that Doug mentioned, but then also take the time through colleagues like Dr. Michael and others that are in some of our regional offices to also hear that input and try and incorporate that into our policies and programs. I'll stop there.
Thank you so much. And it's true, for all that we do, stakeholder feedback and input is very important. It really helps us shape the policies and the programs that we release to the public. So thank you. Any other comments regarding equity, trending, useful data points?
I'll note that we have started to collect a number of measures in our quality incentive programs, pay for reporting and pay for performance, that's really informing, kind of next steps and where we go from here. But that is, much of that work is informed by listening and comments from interested parties, and really a sincere desire to give back information that's useful for consumers and family members and caregivers and all to make decisions. And so we've done a lot of work on our compare site as well, including the recent release of the birthing friendly designation that those that want to know about having care in a safe location can go to the website and look for that information.
And I was only going to add, I really appreciated what Dr. Malik was saying about moral injury and health-related social needs. And one of the ways that we've seen over time that can be a useful intervention is when when an individual patient who's underserved has a trusted source in the community. It might be a community health worker, it might be a peer support worker, care navigator. Those individuals can really help rectify some longstanding disparities in care. And for the first time in this last physician fee schedule, we finalized new codes and payment that basically describe the services of these types of individuals, community health workers, peer support workers, care navigators. And so we're excited about the impact that might also be able to have in this space as well in Medicare.
Yeah, that is really exciting. Thank you for that. Okay, we're going to move on to Dr. Sean Michael. So Sean, you work in the Denver office as a chief medical officer, regional chief medical officer. Our regional CMOs are responsible for working with local stakeholders to hear their concerns and challenges. Can you discuss the need for our CMS to hear the voice of the stakeholder and what your time working with stakeholders has been like thus far?
Thanks, Samantha. Yeah, I really appreciate this dialogue. I mean, my colleagues have teed this up entirely, actually, right? I run into so many people, clinicians and healthcare leaders, who give me a speechless, sort of inquisitive look when I tell them there's a CMS Office of Burden Reduction. CMS has quite the reputation. Most of that image is constructed really not by direct interactions with the agency, but by community lore, by word of mouth, by the culture of healthcare, by what other people say about us rather than direct interactions. And so much of what we're trying to do in our regional locations is really just be a human face, be real people who represent the other more than 6,000 real people at CMS who really do want to make healthcare and health much better. So to really understand burdens, we really have to focus on patients, because one of the ways of thinking about burdens is the stuff that pulls healthcare teams away from patients without adding value. And that care with patients happens in a very local way. And so CMS has to be out locally, interacting with clinicians and associations, societies, hospitals, long-term care facilities, community organizations, state governments, everybody, right, to understand how that care happens, and to understand how we can identify and reduce and eliminate burdens, and understand unintended consequences of our policies, and understand what the clinical world really needs. And that is really the crux of the role of the folks who are in the regional locations, is to be that face, to be the person that our clinical community can go to and have the bidirectional communication, as the rest of the panelists have said. And one of the most fascinating things for me actually has been to hear about what I call our knowledge translation, or maybe message translation gap. CMS invests a great deal of thought and effort into everything that we do, but sometimes that doesn't reach the sharp end of where healthcare gets delivered because it's translated through a telephone game of so many other layers. So we see burden reduction efforts that don't really have the intended effect of deburdening sometimes, because there's well-intended layers of interpreters, sometimes other regulatory folks at the organizational level, sometimes IT or legal or other consultants, all of whom have a really important lens, but sometimes they just don't even believe that CMS might even take away a requirement. It just doesn't compute. And sometimes there are sort of local level factors or organizational factors. Sometimes they're state by state factors or particular geographies where there are just elements that we didn't realize were in the mix in the way that organizations and clinicians were thinking about how some CMS program impacted them. So understanding what those are and being a conduit to both receive that information and also to understand the way that healthcare is getting delivered out there so that we can anticipate some of those things is a really important part of our role as well. And that layer of interpreters sometimes adds, the most risk averse approach would be to keep the burden at the local level in the organizational processes, in policies, even if CMS has tried to eliminate it, because that sometimes is thought of as required by some other program or some other entity that's not CMS, or it's just difficult to remove. And we see that in all the particular burdens we've talked about so far. In prior auth, we see that in measurement, in regulatory standards. The radiology acceptable use criteria getting sunset is a good example, where there are lots of organizations who are not interested in turning that off that I hear about because they have other beliefs or other sort of externalities that they worry about. The evaluation and management documentation codes getting streamlined to basically make documentation less and less burdensome, to be able to build the same codes. Many organizations haven't translated that to their frontline clinicians to be able to actually have them reduce documentation yet, even though CMS has said explicitly that that is one of the deburdening efforts that is intended because of some of these translation gaps. And so events like this, I think, are really helpful. Having real people out in our regional locations is helpful, making sure that our stakeholders know that they can always reach out to us and understand regionally or in our Baltimore location, right, how to reach the right folks who are thinking about these things. And really trying to understand the on-the-ground realities of healthcare delivery, make sure that we're listening carefully, make sure we're communicating our vision carefully, and make sure that we're being out there to understand really where care really happens and what we can do to reduce burdens. That's really sort of our role in the regions.
Thank you for that. And I agree. Within the Office of Burden Reduction and Health Informatics, we ensure that we do reach out and we speak to people at all different levels, because what we have discovered with our RFIs, requests for information, talking to our colleagues within CMS and caregivers, patients, other clinicians, that sometimes it's just a matter of explaining, and having that dialogue. It's also important to share the information. One of the things I believe Jean touched on earlier was that we're all very collaborative. In years, many, many years ago, I know folks would always say, oh, CMS is so siloed. No, we have learned how to collaborate. We want to hear from everyone, and we utilize that information to strengthen our programs. So thank you for that, Sean. Any additional comments regarding stakeholder engagement? Okay, thank you. I do have a question from an attendee. Yes, Doug. This question is regarding quality measures. And let's see. Do you use measures of improvement in health outcomes in addition to quality measurement?
Yeah. When in the creation of the Universal Foundation, one of the things that we were really trying to pay attention to was making sure that we had some health outcome measures there specifically. And so that could be measuring for diabetes, a person's hemoglobin A1C level, for blood pressure control, just making sure that individuals are having their blood pressure well controlled. And so outcome measures don't exist for everything that we would like outcome measures for. And so also when we came out with the Universal Foundation, we recognized that this is a first step and are interested in iterating over time in collaboration with feedback that we get from stakeholders, new quality measures when they're coming out. So there's also quality improvement plans that we have on the Medicare Advantage side. I think Jean can talk a little bit more about the quality improvement organizations, but quality improvement in general is really a strong focus across our quality programs.
Yeah, and I'll add just on the outcome front is really identifying those things that matter most to patients, families, and caregivers, and working on patient-reported outcomes or patient-important outcomes, and the many names that are evolving for that. And I think that's where we're continuing to do work to ensure that, many times patients will say, just ask me how I felt after that treatment, instead of giving me a long survey. So there's work to do in that area, and I think we're making progress.
Okay, thank you. Let me just see if I have any other questions coming in.
I guess while we're looking at that, I would also add that, and Doug mentioned this earlier too, right? The Universal Foundation isn't at the exclusion of wanting to assess the effectiveness of, individual practices or specialties or, particular ways that care gets delivered, right? It's intended to create alignment and a foundation, right? Exactly as the word implies, upon which we can build more specific and granular understanding of how to improve care in specific ways. And so we see that, right? MIPS value pathways are a good example in fee-for-service Medicare, right? We see that where there's a lot of specialty-specific outcomes that are important to link to the Universal Foundation. And for many clinicians who are out there, it's more difficult to see how their day-to-day work might attach directly to some element of the Universal Foundation. And so part of what we'll be adding on to over time, right, is an expanded understanding of how everyone across healthcare can work together to work on that same foundation of sort of what constitutes the highest quality, highest value care for individual people, and view sort of how their piece fits in with that and connect the programs together so that we can have better alignment. But it's not at the exclusion of improvement and everything else too. It's a really foundational element, just as the name implies.
Okay, thank you. Okay, I'm receiving another question. This is regarding CPT codes. How do you see the future of CPT codes for reimbursing providers? to use RPM devices, health coaching, chronic disease management, etc. We've heard that it is difficult for providers to measure and document successful use of these CPT codes, which is now necessary to receive reimbursement. Any future plans regarding this?
I can take that one. So RPM, or remote patient monitoring, really, we started paying for it during the pandemic, in particular, as we saw that it can be really important to keep a lot of patients with certain diseases and conditions healthy. It's historically been used most in the cardiology fields. And I think as its use has grown over time, we've been getting certainly feedback about it. And just this last year, we also made some changes to better allow federally qualified health centers, rural health clinics to better utilize these codes. So that is to say that these are relatively new codes, and we're still interested in getting feedback and thinking about how to incorporate that over time. So thank you to whoever asked the question.
Thank you. I also see a question regarding where can people find information on burden reduction resources. You can definitely go to the Office of Burden Reduction, OBRHI, website within CMS, and there's resources. There's an opportunity to ask specific questions to be connected to the appropriate center or office within CMS, and we will always respond. Let's see. Another question. Who should I reach out to at CMS regarding prior authorization, especially if hindering quality health care? So
I can maybe start and talk about Medicare Advantage, but if others want to chime in other settings, that would be great. So in Medicare Advantage, some of the changes that I talked about in prior authorization are going to go into effect in January 1st, 2024. And so we certainly are interested in hearing about how the implementation of these provisions is going. Within the Medicare Advantage program in general, there's a complaint tracking module where if an individual has a certain complaint with regards to Medicare Advantage, CMS wants to hear from you to make sure that all of our regulations are being followed appropriately and that people are getting access to the care that they need. And so we encourage you to submit a complaint if you are finding that the regulations that I discussed today are not being followed in 2024. And that's specifically for Medicare Advantage.
I think across, what you just said, Samantha, about sort of the Office of Burden Reduction Health Informatics website having sort of some broad resources is a good one that's actually useful for questions like this too. And it's also a resource that we want to make available out of all of our regional locations too. And we, as one of my colleagues in Denver likes to say, we're really good switchboard operators. We can often work across the agency to find the right component, kind of depending upon what the specific program area is or what the specific question is. But that's part of what I mean by that human face is, I want you to be able to call Sean and I can help you with trying to sort through sort of what's the issue on the ground that you're facing. And there are colleagues and analogs across the country who feel that same way, who really want to be the person to help guide in some of these things. And even if we can't directly fix the problem ourselves, we're happy to navigate through the agency. It's, the healthcare is complex, CMS is complex. And so some of the cross-cutting entities like the Office of Burden Reduction Health Informatics, like the regional locations, have a lot of ability to help cut through some of that if you have questions too.
Yeah, I would just emphasize reaching out to your regional office, maybe to directly answer the question. And then I'll just say from the Medicaid side, if it is specific to either Medicaid fee-for-service or Medicaid managed care, CMS also has state leads for every single state, the District of Columbia, and the territories. So the answer to your question is triangulated, sort of based either on geography and or by which CMS program you are serviced by. But to Dr. Michael's point, there's no wrong door. So like if you go to the OBRI mailbox, if you go to the regional office, if you find your Medicaid state officer, there's a series of switchboards internally, and we will make sure that gets to the place that it needs to go.
That's so true. Thank you, DT. I have a few more questions and then we will start to wrap up. Let's see. How do you ensure that quality measures do not disproportionately adversely impact physicians who manage patients with disparities?
It's a great question. I'll start, and then maybe Dr. Jacobs and others, I'll turn it over to you. We are keenly aware of that. Many of our programs include some form of risk adjustment. And risk adjustment, both in terms of the clinical and social complexity of an individual or of a patient panel, and or the complexity geographically, let's say, of individuals living within a certain region. That then impacts things like upfront payments, sort of what so-called advanced payments, to be able to address those needs. It also can impact upside savings or upside risk only in value-based payment arrangements, and in some cases can impact quality benchmarks. So we try to be thoughtful about it, both in the risk assessment, but also in the payment and quality assessment. Dr. Jacobs, I'll turn it over to you for more detail.
No, I think that was perfect. I won't say too much else other than a lot of these programs, also the ones that I had mentioned earlier, recognize that when a clinician is providing high quality care to underserved populations, that there should be an extra reward. That was the concept of rewarding excellence for underserved populations that I spoke of earlier.
And I'll say in our programs, pay for performance, pay for reporting, any of our programs, we try to think about that upfront. What's the impact? Get the input from practicing clinicians, but also from those that are receiving care as well as we go through development. We have, of course, the public comment period. And then I will say for this, our administrator, from day one, had us to think through any policy that we would propose. What is the impact on equity? Who's going to be served by this? And so anytime we put something forward, we have to have that consideration as well.
Thank you. Thank you. So we're going to go ahead and start wrapping up. And before we end the session, I would like to hear from each of you. What is one thing that you would like people to know about CMS's efforts to reduce administrative burden? Jean?
Oh, okay. Go ahead, Jean.
So I think the thing that's been highlighted is hearing what those burdens are, considering the levers, and we have many, particularly within CCSQ, that we can pull to impact change. And so and one of the things I just want to commend your office too, Samantha, is the journey maps that you do. They really point out the pain points and they validate what we hear from those interested parties that communicate with us. We do use that information. That's the one thing I want people to understand. Every comment, every pain point, all of that is considered as we go through with policy making. So please continue to comment.
Thank you. Aditi?
Yeah, thanks for the question. I would just say we're human beings too. Like, you know, to the extent that people think of, and Dr. Michael alluded to this, right? To the extent that people think of CMS as a big black box with nameless, faceless bureaucrats, like hopefully you realize that we come to this work, I think, for the same mission and purpose that many of you do, right? And so if I could just underscore one thing, it's that we share the same mission, which is that the tens of millions of people impacted by our programs get the best possible care that they can. and that the people that are delivering that care, be they individuals, groups, facilities, whatever, have also the tools and resources that they need to succeed in delivering that care. So we're on the same team is really the punchline I'm driving towards. And we would welcome, as Jean said, we would welcome your input on how we can work better together.
Thank you.
I'll maybe add, so that was just, first of all, +1 to that. And then I also wanted to mention just, I think historically some of the challenges with burden has been created by, and Samantha, you alluded to this earlier, like the different silos of CMS not really operating collectively across the agency. And hopefully you've heard today, through really concerted efforts across the different centers and offices within CMS, we're really working together in ways that we haven't before, with burden reduction being one of those priorities. And so I think it's really nice, like working with such talented colleagues across CMS towards these common missions that we described. And we're hoping that it makes care delivery less burdensome for clinicians and overall better for patients too.
I agree with all of those things. That there's such poignant comments, and I would sum it up by saying, don't assume that we know, even if it seems obvious. Don't assume that we already know, because it's entirely possible that the nugget of information that you can individually provide us is one of the keys that sort of unlocks the understanding of how all of these complex interrelated parts connect, and it is too easy to assume that they must know about this, right? Don't assume that we know.
Thank you. Thank you all. Thank you all very much. And I'll add to that from OBRHI perspective. You're absolutely right. I co-sign all of that. We ensure that we release RFIs. We have the human-centered designed journey maps. We conduct surveys. We conduct listening sessions. And still, we hear things that we have not heard before. And we're like, wow, we do media sensing. So definitely important to keep the information flowing in. And in addition to that, as has been stated, we all work collaboratively and collectively within CMS, but it's also important to understand that within the external community, clinicians, healthcare systems, et cetera, we need to hear from you in a concerted way where we can all partner to make optimization of patient healthcare delivery better, right? So first, let me thank you, each of you, for your time today. This has been wonderful, thought-provoking, and insightful. I'm sure that our attendees, over 2,500 at this time, have learned so much, and of course, have written down each and every one of your names, because Dr. Michael said you can reach directly out to him and everyone. So thank you so very much. And now we're going to have, just as I stated, the importance of hearing from hospitals and healthcare systems, we're going to have the team from University Hospitals come to discuss their work on policy burden reduction.